Good afternoon, everyone. Happy Columbus Day yesterday. We are now in the NIDA conference room. We have our guest speaker, Kenzie Preston, here with us. Dr. Preston is from NIDA Intramural. She's being a senior investigator at Intramural, and a number of years ago, she started adopting the technology and doing research with all kinds of mobile technology, wireless technology, put it this way. Yeah, and we, this is the first webinar we scheduled for the data science task force, and we plan to have regular webinars in the future. And let me just ask, Lisa Marsh, are you on?
Yes, hi, Betty.
Oh, thank you very much. We have tapped Lisa for identifying many of the speakers in the future for our technology focused webinar. But of course, we like to hear from all of you, recommendation to us. Let me say a few words specifically about this presentation. This is Kenzie's collaboration with Dr. Santosh Kumar from University of Memphis. Dr. Kumar is a computer scientist, and he has a BD2K grant, and he's also having a NIDA grant, and he has been working with Kenzie on this particular project for a few years. And when we first heard about this, it was a very interesting approach to measure cocaine or stimulant intake other than use urine analysis. At the NIDA PI meeting, you all heard Nora talk about the desire of seeking a variety of outcome measures to measure drug use instead of urine. But in order to validate this, you always have to use urine as the reference. We were hoping this technology may help us, expand beyond urine analysis. As you know, urine analysis definitely is not ideal. So without further ado, I'll ask Kenzie to talk about this particular subject, and I believe she and Santosh has published a number of papers on this.
Yes.
Okay.
And actually, I took the liberty to broaden my topic, and so that's one component of it, but I'm covering more generally the mobile technology.
Wonderful, wonderful. Please, that's great.
Okay. All right. So thank you for the invitation to present. So my lab's been doing work for quite a few years on behavioral pharmacology in the laboratory, as well as doing randomized clinical trials. And then in the last few years, we've added our mobile health toolbox to our armamentarium for research. And so what I'm going to talk about today is the mobile health toolbox, our use of it in clinical trials to go beyond does it work in order to assess mechanism, to talk about our geographical momentary assessment, and then Santosh's work with the intensive ambulatory physiological monitoring. And then a little bit about what we're thinking about for mobile interventions for addiction. So our mobile health toolbox includes self-report on electronic diaries. A few years ago, we added real-time location with GPS trackers, so we would know not only what people were feeling, but where they were feeling it and where they were spending their time. And then most recently, we've added these biosensors, which we think is really the wave of the future. So I'm going to first talk about a project where we used our mobile health toolbox in the context of a clinical trial. So that trial was based on the reinstatement model of drug relapse, where animals are trained to self-administer Once their behavior is stable, they go through extinction where pressing the liver no longer delivers drug, and then they're tested with different things to see what would lead them to return to drug seeking. And this model has a lot of important features. The self-administration aspect, animals self-administer the same drugs that people do, and also the same things that reinstate responding are things that we believe lead to relapse in humans, which was drug priming, drug cues, and stress. And so the idea is that this model has been adopted to screen medications with the idea that medications that block reinstatement of drug seeking might be useful for treatment. And so this is just a brief example with the alpha-2 agonists. These are rats that are trained to self-administer either heroin, cocaine, or a combination of heroin and cocaine. And what you see here under 0 was the pretreatment with placebo, and when animals were exposed to a foot shock or a drug cue, they're responding for drug increased. However, when they were pre-treated with clonidine or lofexidine, they're responding for those, the reinstatement was blocked for foot shock. However, for lofexidine, which they also tested exposure to drug cues, it actually did not block reinstatement for drug cues. However, other laboratories have since studied the alpha-2 agonist for cue-induced reinstatement of cocaine seeking and found that they do block reinstatement. So the question is, will these drugs work in the same way in humans? So we decided we would test clonidine, which is an alpha-2 agonist. It's orally effective. It's been available for more than 40 years in the United States, and we know it's safe. It's already used off-label in a drug-using population to treat opiate withdrawal. So our first step was to do a lab study where we evaluated the ability of clonidine to reduce stress-induced and cue-induced cocaine and heroin craving. We enrolled non-treatment seeking cocaine users, 59 of them, and randomly assigned them to 3 different doses of clonidine, 0, 0.2, and 0.1. The drugs were delivered in double-blind conditions, and we gave a single dose of medication. We waited 3 hours, and then we exposed them to a cue and a stressor. And these were done with guided imagery scripts in pairs, neutral and stress and neutral and drug, and they were counterbalanced across people in the different groups, and we looked at craving before and after each pair. And so the results of that study are shown on this slide. The outcome measure is cocaine craving on a visual analog scale, and this is in the group that got clonidine placebo, and you can see that both the stress script and the cue script increased craving for cocaine. The group that got the lower dose of clonidine, we saw blockade of the response to the stress script, but not the cue script. But at the highest dose of clonidine, 0.2, we did see blockade of both scripts. So it did work in the human laboratory. So our question was, how about the clinic? So we tested clonidine for relapse prevention in opioid dependence in the context of opioid agonist maintenance. Even though buprenorphine and methadone are very good medications, in fact, people do relapse, and perhaps one reason is that opioid agonists block drug-primed reinstatement but really don't have any effect on stress-induced reinstatement. Our alpha-2 agonists look like they block reinstatement in response to stress, maybe have an effect on cue reinstatement, and so maybe this is a good combination of drugs that could help prevent relapse. So our question is, does it work in the clinic? If we combine clonidine with buprenorphine, will time to lapse or relapse increase? And we can also ask, how does it work? So will clonidine's effects be exerted by decoupling stress and or drug cues from lapses? And I guess as a translational question, we want to know whether foot shock and drug cues that are applied to a rat would be analogous to the stressors and cues that heroin users face in the real world. And so this was the design of our trial. We tested clonidine for relapse prevention in a randomized double-blind clinical trial. We enrolled opioid-dependent treatment seekers. We tested clonidine 0 milligrams versus up to 0.3 milligrams per day. So people were enrolled and begun on standard buprenorphine treatment with weekly individual counseling, and they actually came to our clinic every day to get their buprenorphine. And we monitored their drug use with 3 times a week urine drug screens. This was a relapse prevention trial, so we used contingency management to reinforce abstinence at the beginning of the trial. People were given a quit date, and they were required to test negative for all of the urine, in all their urine tests for a 2-week period, and only if they met that criteria were they randomized to receive clonidine or placebo. At that point, they began clonidine and they received it in the clinic each time they got their buprenorphine. There was a 2-week induction period after which we stopped the contingent vouchers and people remained on the clonidine or placebo plus buprenorphine plus counseling for 12 weeks. And then at the end of that period, they had a 2-week taper. So the other aspect that we did is we looked to see if we could look for a mechanism by using our mobile technology, that is ecological momentary assessment, during the period of time when people were getting clonidine. So for our EMA, we asked people to tell us in the last hour, did you see heroin, yes or no? Asked them to rate how much they craved heroin, how much they were stressed, and they rated them on a 4-point scale from no, definitely not, no, maybe, well, yes, maybe, and yes, definitely. And we asked them to do this 4 times a day at randomly prompted times during their waking hours. So this is the demographics, and we had 57 people in the placebo group, 61 in the clonidine group, and overall there weren't any differences in our groups on demographic or drug use histories. So the question, does it work? This is time to relapse, one of our primary outcome measures. We defined a lapse as 1 positive or missed urine specimen. The clonidine is the dark line and the placebo is the lighter line. And indeed, we found a significantly longer time to lapse in the clonidine group, although there was no difference on time to relapse. Our other primary outcome measure was longest duration of continuous abstinence. Each of those dots is a participant. The lines, the horizontal lines are the means. So for placebo, that was about 25 days, and in the clonidine group, it was about 35 days, which was a statistically significant difference. And I especially want to point out that we had quite a few people that went through the entire treatment without a single lapse, that is, not a missed urine or a positive urine. So for does it work? Yes, clonidine given in conjunction with buprenorphine increases duration of abstinence and time to lapse. So how about the mechanism? So these are data from our EMA. What I'm showing here is the likelihood of reporting heroin craving in the context of how they rated stress. And so what we found is that overall there was a significant main effect of stress. So the higher they rated their stress, the more likely they were to also report heroin craving. We also saw a main effect of clonidine such that within the random prompt, in the placebo group, 11.8% of random prompts people said, yes, I'm craving heroin, while only 6.3% were craved heroin in the clonidine group. There was also a drug by stress interaction, such that at the moderate levels of stress, the clonidine group was significantly less likely to also report craving heroin. However, when we went up and looked at the highest level of stress, there was no difference between the groups. This is the data on the drug cues and heroin craving. So overall, there was a main effect of exposure. So when people said that they had seen heroin in the last hour, they were also more likely to report that they were craving heroin. There was a main effect of clonidine, so overall they had fewer heroin craving positives in the random prompts. But importantly, there was no drug by exposure interaction. So it didn't appear that there was any specific effect of clonidine on response to Q exposure. So does clonidine work in humans using the same mechanism as in animals? Our evidence suggests that it's so. The stress and the craving were decoupled by clonidine, while the Q exposure and the craving were not. So I think if we're thinking about mobile technology, we want to measure cocaine, but I think there are other things that we might do with mobile technology. So these results are translational. A medication that was identified in a preclinical lab was effective in the clinic, and we got positive results, sort of supporting the idea of the validity of this animal laboratory. And importantly, for clinicians and patients, the EMA results identify circumstances under which the clonidine maintenance is most likely to be beneficial, and that is during exposure to moderate but not severe levels of daily life stress. And we just published this. The next area I want to talk about is what we called geographical momentary assessments, and we are interested in using this to investigate individual environmental influences on drug craving and use. So the study design, we had opioid-dependent people in opioid agonist maintenance. They came in every day and got medication and got weekly counseling with 3 times a week urine drug screens. The study itself lasted 18 weeks, and at the end of the 2nd week, people were given a PDA or smartphone and a GPS, and the PDA prompted them to make entries at 3 times per day. They were also asked to initiate an entry anytime they used drugs or had a stressful event. And our GPS unit recorded location every 15 minutes or movement of 20 meters, whichever came first. And importantly, we met with our participants every week, and we compared what they reported on the EMA for drug use against the urine drug screens, and we actually reinforced, gave them an incentive if those things matched. So we got better compliance with reporting drug use that way. So one of the things that we did is we can do with these data is to look for a temporal relationship between stress events and drug use. And so I'm talking about the event contingent entries where people said, I felt stressed, overwhelmed, or anxious more than usual, and the events when they said, I used cocaine. And so what we're interested in doing is looking whether there are any changes in stress events in the days leading up to cocaine use. And to do that, we took all of the stress events that people reported, and we divided them between those that had occurred within 72 hours of a drug use event versus not. And then those that occurred in those 3 days, we actually binned them in 24-hour periods, and we looked at the ratings, so the severity of the event. And so this is the result of that analysis. How bad was the stress was one of the ways we asked people to rate their event. And what we found was there was a significant increase in how bad the stress was in the 3 days leading up to cocaine use. So there looks like there is a relationship. However, not all participants actually showed this pattern, and not all drug use events were preceded by a stress event. And so I think this is one of the things we can look at as maybe an individual characteristic that we might incorporate in a just-in-time treatment for patients. What else can we do? So one of the things we did is to map self-report and onto the city. This is Baltimore. Each of those little black dots is where an EMA entry was done. The red indicates high negative, so that'd be high heroin craving, high stress, low positive mood, and blue indicates a low negative, so it'd be an area with low heroin craving and high positive mood. And so we asked the question, is there a relationship between self-reported mood and environment?
The stadium there, the stadium.
The stadium?
Yeah, the football stadium.
Oh.
Next to the negative.
I don't know. I don't know where. Oh, yeah, I know where the football stadium is. Yeah. Yeah, that's not a great area if you're walking
Yeah.
around. So the environmental measure we actually ended up using was the Neighborhood Inventory for Environmental Typology, which is from Deborah Furholden, and she sends trained observers out into the city where they collect data on 140 environmental variables at more than 500 locations. So she was very kind, gave us our data, and so we mapped it in the same way we mapped our self-report. Each of those little black dots is where they evaluated a block face in Baltimore. Red is high negative, blue is low negative. So if we're going to think about comparing the self-report to the mood, or to the environment, one way we might do it is on a neighborhood level. So we have this EMA entry on the left, and we could compare it to the characteristics of this neighborhood. But of course, we don't know how long the person had been there, and we also don't know how homogeneous that whole neighborhood is. Chances are it's not particularly homogeneous. Another way would be to look at track levels, and because we had people were carrying GPS units, we could look at the half hour before they made that entry. We could just take into account a narrow band around their path, and we could even correct it for the amount of time that they spent in any one place. And so that's a half an hour before the event. That's a half an hour before that, so an hour before. And we can keep going back in time in half-hour increments. And we actually looked at the path for 12 hours prior to each EMA entry. And so we could calculate environmental exposure based on the tracks. So we have published that analysis, and what we found is that indeed there is a significant association between mood and environment. This is just one comparison, stress versus physical disorder. And what we found was that indeed that was significant. However, the direction was the opposite of what we had initially expected. So you can see where that EMA entry occurred is a high stress, but it's a low physical disorder. And then this is the results for the cumulative time level analysis. And so that first dot is the half hour before, the second dot is the hour before, the second point is the hour and a half, and so forth. And what we found is that the effect was in the same direction, but as we included more time going before the EMA entry, we actually strengthened that relationship between environmental exposure and self-report, and that peaked about 5 hours before. So our results were consistent, but in a counterintuitive direction, and we've now replicated these findings in our larger study, so we think this is actually a real effect. So given that we could see this strengthened relationship when we took into account time in the past prior to the EMA entry, we thought, well, can we actually predict mood from the GMA? So we used a machine learning model called Random Forest to develop an algorithm to predict mood and craving 30, 60, and 90 minutes into the future. So this is the results from the pilot study. This is negative mood predicted 90 minutes into the future. This is observed negative mood graphed against the predicted, and you can see we got a good R value. Actually, I can't read it from here, 0.92. And the way these work is that you take a part of your data, you develop the algorithm, and then you take the rest of your data and you apply the same algorithm to see if you get the same relationship. And indeed, we do get an R of 0.97 in the validation data, which was a 30% reserve data. This is from our second larger follow-up study with 97 participants. This is predicted positive mood, and these training data, we used a 50-50 split, and we got a good R value of 0.97.
Yes.
And for our validation data, we got an R of 0.82. And we found, because we had a larger N, we were able to include more variables to control for, so we controlled for EMAs made at home, participants' demographic characteristics. So we're very excited about these data. And of course, that's predicting mood, and that's also on across people. What we really like to be able to do is predict drug use with GMA for an individual. And so one of the things that we've been doing when we look at people's patterns of activity, this is one person's path on day 5, day 6, day 9, day 10. This is his path on day 2, day 4, and day 8. And so it looks like a pattern there, and it turns out the ones on the left were the days when this person was abstinent, and on the right are the days when he used cocaine. So we decided that we would apply a machine learning algorithm to see if we could calculate prediction for cocaine use, and we used the maximum entropy or max-ent model. And the input was the geographic location, time of day, and our NIFTY data. And our output was the probability value. And we did it again for a single individual. So this was the predicted cocaine use. So this is that blown up. What is graphed there is the predicted cocaine use at every half-hour interval going through the person's entire treatment. And those are the light blue lines. And those vertical dotted lines are the actual times when the person self-reported using. And the horizontal lines are the probability quantiles for self-reported use. So at the 0 is when all of the probabilities when person actually used that were calculated were above that line. So if we're thinking, how would we use these kind of things to help a person stop using? Well, we could warn them every time their probability got above that 0 line, but we'd have a lot of false positives. Or we might not want to have very many false positives, and we would only warn them if their calculated probability went above the 50% mark, but then we'd have a lot of false negatives, or we'd miss a lot of drug use. So I think it's an empirical question, is where would we dial this in that would be optimal? And it might be that it varies for different people. It might be that it varies based on how long they've been in treatment. I think those are kind of questions that we can look in the future.
So that's precision medicine.
Yeah, that's right.
Very good.
So we also were kind of curious, so where is this person going? Well, those white circles there are the NIDA IRP where our treatment program is located. And the little red circles are Lexington Market, which is a food market in Baltimore, but it's also a well-known drug market. We can also look at craving and activity space. So this was a path on 3 different days when this person did not crave heroin. And this is 3 days path when he did report craving heroin. So again, that's our location of our program. And it turns out, looks like he might have been going to the parole and probation office. So that could be one of the links between environment and craving and drug use. So another thing we've been doing with these kind of data is figuring out how to visualize it. So we've typically used a 3-color map for our environment, but we can turn that into a monochromatic graph, with dark being the greatest disorder and light being the least disorder. We can map the density of our participants' self-reported drug uses, as are heroin uses. And then you can actually merge those pictures, and so you can see where those densities fall relative to the disorder. And you can go on Google Map and actually pull up a picture of that location. And so a lot of our drug uses occurred in places where we might have expected in kind of bordered abandoned buildings, but really a lot of them occur in regular residential type areas. And
would you share this with the police? I mean, so that they know where the activity is?
No.
Okay.
No, we wouldn't.
They need to have these maps.
I really think they know where the drug use is better than us, actually. And then that's where Lexington Market is, and you can see it's a little pink, but probably people buy there, but they don't actually use there. And then the last part is our collaboration with Santosh with intensive ambulatory physiological monitoring. So I think we have really good tools, but there's some limitations, particularly with the self-report, because it's intermittent, it's burdensome. Wouldn't it be nice if we could just put a sensor on people that could be continuously monitoring them? And so we've been collaborating with Santosh with his AutoSense. We just finished data collection on a device that we can calculate circadian rhythm and look at that in relation to drug use. And we started a collaboration looking at sleep quality with investigators at Hopkins. So this is the AutoSense device. It's a chest band that measures respiration. It also has sensors for GSR and an accelerometer in there. You can add additional sensors, the armband, which we didn't use, and it has ECG leads for, and what happens is the data are sent from the sensors to that little gray box, and the gray box then sends them intermittently the data to the cell phone. And this device was developed by Santosh Kumar at University of Memphis and Emory Ayrton at Ohio State University, whom I'm greatly indebted to. They're great collaborators. So for this study, we did it on top of our ongoing GMA study. So participants wore the AutoSense for 4 weeks, 1 week period separated by at least 1 week. And during that first period, they participated in stress sessions as well as drug cue sessions. So these are the data yield from that study. So we enrolled 42 people. They gave us 922 days of data, and we only had 4 people drop out. So one of the things we were interested in was, well, what did people think about wearing the AutoSense device? So we had them complete a usability and acceptability questionnaire. People said it was either easy or very easy to put on the device. It was easy or very easy to use the smartphone. Mostly they didn't feel too self-conscious wearing it, but some people did. And it was a little bit bulky, especially that little gray box. It wasn't universally comfortable. Some people found it fairly uncomfortable. We asked people what they liked least about wearing it, and probably the being uncomfortable and being burdensome was in about a quarter of the population, but almost half people said they didn't have any problem wearing it. Nothing they disliked. What they mostly liked, though, was actually being able to see their heart rate, and so they could actually look at, and that was one way to make sure it was actually working, and we asked them to check it from time to time, but I think we can probably all relate because we all like looking at our Fitbit numbers, and so it's kind of along those lines. Let's see. So another, got a little bit messed up there. So on average, we got 11 plus 8.8 hours per day of respiration data and 11.3 hours per day of good ECG data. We also had good response on our EMA, lots of smoking self-reports, craving self-reports, and so forth. So how did we come to these numbers about data yield? Well, you need a denominator. So in order to calculate the total possible amount of time that we could have collected data, we looked at the active portion of the day from the first time that people first put on the device to the last time they took it off, because sometimes they would take it off during the day. They didn't wear it at night, and they couldn't like take a shower wearing it. And then we looked at the acceptable quality of the sensor data. So you can see on the left is the ECG data. The output needed to be, on the left is the acceptable. If it didn't meet that criteria, it would be unacceptable. And on the right is the respiration. So there was a little more latitude in what could be considered acceptable data for respiration. This is a pretty complex system, so there are lots of points of possible failures. So it doesn't work if your phone is off. It doesn't work if that sensor, that little gray box, is turned off. It doesn't work if the sensor's off the body. And even if those are on the body, there are possible ways that you'd still lose data through loosening of the attachments or putting the leads in the wrong place. And then another place the data can be lost is between the little gray box sending the data to the cell phone. So Santosh's group actually did an in-depth analysis of this to figure out what worked and what didn't work. And so overall, people's possible active period was 14.5 hours approximately. Some time was lost because the phone wasn't on. Some, not very much time was lost because of the sensor being off. And not much was lost when the sensor was on the body but not actually correctly on the body. But a fair amount of data was lost because the data weren't acceptable. So data were being received but not acceptable. And so when they did a further analysis of that, the largest amount of data were lost due to attachment loss and specifically intermittent loosening of the wires to the ECG. And they actually graphed that. So that's time across the day. And you can see the frequency of loosening per hour increased as people wore the device. And they found a similar pattern in students who also, in a separate study, wore the AutoSense. So what worked and what didn't with the AutoSense? So the wireless link was good. The physical separation between the sensors and the phone wasn't a major issue. The sensor lifetime was acceptable. The respiratory sensor attachment was robust. One of the biggest problems was that skin contact requirement for ECG. And then the phone being off. And we really didn't know why the phone was off. It might have been because the batteries ran down, and probably we've all experienced that. Or people just turned them off. And another way that we could have, and actually we did adjust, was to increase the number of hours that we asked people to wear the device. So we did that during the study, and we paid them extra to wear the device even longer. But if you had a device that didn't require ECG leads and didn't have to be taken on and taken off and put back on, that would be a big improvement. And this is actually reported if people were.
And if you do it with teenagers, their phone will never be off.
Yeah, and probably never away from their body.
Never away from their body.
Yeah. So one of the questions we ask is, can we relate these physiological changes to self-report? So we did the random prompt entries 3 times a day, and we asked people what they were doing, how they felt, whether they were craving, and then they made event contingent entries anytime they used drugs or had a stressful event. So these are the data for 2 measures of physical activity, watching TV and walking. So this is heart rate plotted against what we did is time. So for time 0 was we lined up all the EMA entries and made those times 0. And we looked at the time 30 minutes before the entry and 30 minutes after. Because remember, these are just randomly happening, and we're interrupting ongoing behavior. So there was sort of no start or stop to these kinds of things. And so what we found is that when people were watching TV, they had significantly lower heart rate than when they said they weren't watching television. When they were walking, they had significantly higher heart rates compared to when they said they weren't walking. We have, this is a couple of measures of positive mood, relaxed and happy, and you can see people's heart rates are significantly lower when they either said they were relaxed or happy. And these are 2 measures of negative mood, that is feeling stressed or being hassled recently. And you can see that we had higher heart rates when they felt stressed or were hassled. And these are the timelines for heroin craving and cocaine craving, and you can see that they had significantly higher heart rates when they reported that they were craving. So these are the data from the drug use reports, and this is even more complicated because what we did is line up all the EMA entries at the time when people said they used. But of course, nobody used and immediately made an entry. And in fact, it was quite variable, the time between when they used and when they actually told us they had used. So the drug use occurred prior to that point. And so to take into account all the variability, we looked 2 hours before the entry and 2 hours after the entry. And we also asked people to tell us if they used, how much they used. And we asked them to report it in dimes, because in Baltimore, that's how people talk about quantity. And that's about $10 worth. So that's 2 dimes in red versus 1 dime in blue. And so it looks like we can see a dose relationship in heart rate based on their self-reported cocaine.
Are those self-report all retrospective?
Well, they're supposed to make the entry as soon as they use, so it's somewhat retrospective in that they didn't report it till after they used, but it was pretty close in time. And this is cocaine versus heroin. Cocaine's in the red and heroin is in the blue. In the green, and you can see that, of course, heart rate was higher when people used cocaine versus when they said they used heroin. And sometimes they said they used both heroin and cocaine, and if you look at those 2 hours before the 0 point, it kind of goes around, up and down. But if you look afterwards, it kind of averages out in between the heroin and the cocaine. So I don't know if that's just the averaging of the pharmacological effect or what.
What about smoking cigarette?
We haven't looked at that.
Do you think they will, but these are study subjects. Did you instruct them that when you use cocaine, don't smoke, or when you use heroin? No. Okay.
So yeah, so it's possible that smoking or anything else that they're doing is actually all averaged in there. Yeah.
What about drinking too? Did you, no alcohol drinking? Did you measure that?
We asked them if they were drinking, and we didn't take that into account.
Do you have grasp of correlation between watching TV and use of cocaine?
We have data from EMA when people are actively using cocaine, not necessarily at that time.
But you cannot overlap them, for instance, and see whether the watching TV decreases the use of cocaine?
We almost can never make a causal association with these kind of data, but yeah, I'm trying to remember. I think we've published those data. I'll have to go back and actually look at that particular relationship.
Goes down while they're watching TV.
Yeah.
It feels like they are very relaxed, and that's a good activity for the patient.
It may depend on the show that they're watching.
Yeah.
I mean, CSI Miami
They'll
versus
fall asleep no matter what.
Dancing with the Stars.
Yeah. Actually, as you'll see in a little bit later, because with Santos, with the AutoSense, it actually does give you actigraphy, actigraph. So you'll see. Yeah, no, it's okay. So we've published that in drug and alcohol dependence. But we're at the real holy grail, of course, is to take our sensor time series and turn that into a biomarker sequence. So to apply computational models, so we don't have to ask people what they're doing, but actually can infer what they're doing based on their physiological state. So one of the things that Santos group has been doing is to developing a methodology to detect smoking from respiration data, which they've published. And what they did is they did lab studies where they had people under known conditions of smoking. They develop an algorithm and they apply it to field studies. And of course, that's with a wider range of conditions. And so the way they did it is they evaluated the tracer for the respiration cycle to identify the key elements. They looked at different respirations based on what different things people were doing, and they looked at the interference and what could keep them from identifying smoking or puffing. And it actually turned out that conversation was one of the more difficult things to differentiate, or would make it hard to separate conversation from smoking. But nevertheless, they did come up with an algorithm that was 90% puff detection in the lab and about 87% in the field. So could we do the same thing with modeling cocaine use from the ECG data? So we worked with Annie Umbrecht, who had a cocaine administration study going on at Hopkins, and her participants wore the AutoSense during her study. These were inpatients. They got doses of cocaine IV ranging from 1 to 40 milligrams, and in some sessions they got multiple doses. And they also collected AutoSense data on days when people were not getting drugs. And then, of course, we had our field study that I already described to you. So, of course, we had 42 people who wore this device for 922 days. They reported 211 drug use events. But it turns out that only 40 of them actually ever reported using cocaine. And they made 142 cocaine use reports. And they reported a range of doses from 50 up to 600 milligrams and a wide range of routes. So out of those 142 use events, 22 of them occurred when people were not wearing the sensor. 25 of them they used after they had taken the sensor off. 3 of them while the sensor was removed while they were actually using. The accelerometer data weren't working for 6 of those events. 6 of them, the ECG data were missing. 53 of them, the ECG data weren't acceptable. So overall, out of all of that, we ended up with 27 uses from 13 participants with doses ranging from 100 to 400 milligrams. But we did have 320 person days of good data. So this is a sample of the data from Annie's lab. That's activity at the top, and what's shown with the red line with the green is the RR interval, which is the inverse of heart rate. So as RR goes down, the heart rate is going up. And so there are 3 injections there, 1, 20, and 40 milligrams of cocaine. You can see a nice smooth change in heart rate. And these are data from the field. Not quite so pretty. And that's one self-reported cocaine use of 100 milligrams. So in trying to develop an algorithm from the lab and apply it to the field, there were some challenges. So there was a wide variation in dose, so up to only 40 milligrams in the lab, but people saying they'd use 400 in the field. There was a wide range in routes, so all IV in the lab versus other routes in the field. And then the other thing that was probably the most difficult was the fact that people were sitting in a chair in these cocaine administration studies, whereas they were actually pretty active in real life. So people use cocaine and move around. They don't necessarily sit around. But they did develop an algorithm. They used a moving average convergence divergence approach, which is actually stock price tracking software, and they use that to identify candidate windows. And then to distinguish the heart rate changes from physical activity versus cocaine use, they included in their model the known parasympathetic nervous system changes from activity, as well as the rates of cocaine metabolism as part of this model. And also, because we were monitoring cocaine use very closely in our outpatients, there were some days when we knew they had not used. And so we had some activity episodes on cocaine-free days that we could include in the model for each individual. So overall, the data processing steps included pulling together the data, throwing out any bad data where the data quality wasn't good, and then applying the data, the smoothing and window analysis, and then pulling out those good recovery segments and applying the cocaine dampening parameter and the activity recovery parameter to say whether or not a window was a cocaine use or a non-cocaine use event. And so this is a snapshot of the results. So each of those little X's indicates one of the possible windows that they evaluated for a cocaine use event. You can see activity in our R interval, and what they did is they identified 2 possible cocaine use events out of all of those for this one episode of wearing the AutoSense. So overall, they were able to develop an algorithm with good sensitivity and specificity for both the lab and the field. And that's now published. So what are we doing now? So one of the things we're looking at is physiological response in the environment. So it would be nice to know if we could differentiate the kind of place where people are based on their physiological parameters, and also to see whether there's any relationship between disorder and physiological response. So just on a preliminary analysis, what we found, even though our self-report, people are saying that they're less craving and less stressed in more disordered areas, what Santos's group is finding that in fact they are seeing increases in heart rate in more disordered areas. So it might be that people just don't recognize that is having a physiological impact on them. And he's also developing a stress inferencing algorithm, and this is the likelihood of stress for a single individual mapped onto the disorder scale. That's another thing we're looking at. So moving forward, we would like to apply some principles to developing measures of behavior. So we need things that would be zero burden, so they could be used in large scale and with people easily adopting them. They should be continuous, so we don't we get all the times and not just when, scattered times. It needs to be robust, so it works reliably in the field. It needs to be clinically useful, so we would like to choose something where we can validate it, but if there's not already good measures out there, or that it's something that would be predictive of a clinical outcome. And it should be something that's novel, something that would fill a gap or represent a new capacity. So our long-term goal is to use the smartphone as a treatment delivery device. So we would collect patient-specific data. We could process those data, use our algorithms to determine when people might be at risk for using drugs, send that information back to the smartphone, and then deliver just-in-time treatments or relapse prevention. And I want to acknowledge my collaborators at the IRP, particularly our IT group, without whom we could not do this work, and our study participants and staff, the AutoSense team, Annie Umbrecht at Hopkins, and then our support from the NIDA Intramural Research Program. I'll be happy to answer any questions.
Very good. Thank you. In the interest of time, anybody participating in this webinar, you have a question?
Jody, I do. This is Lisa. Can you hear me?
Sure.
Okay. Hi, Kenzie.
Hi, Lisa.
Thank you for that. Hi. Thanks for that terrific presentation. It's just great to see the evolution of your work in this space. And it's interesting to look at the work that you started moving from the lab into EMA focused work and then into the sensor space with Santosh. And I'm wondering, as you think about the sort of next iteration of this work, what are your thoughts about the role of sensors that are embedded on mobile devices as part of the suite of data collection tools that you might consider using? So you pointed out that there are lots of challenges with all of these wearable sensors and lots of potential points of failure and challenges with adherence to use of these kinds of tools. But we know that mobile devices, smartphones, have extraordinary computational capacity and a large number of sensors embedded on them. And there's a lot of interesting work that hasn't been applied yet much to the field of substance use, but looking at things like sleep onset and offset with just passive sensing of ambient lighting and activity levels and such, or analyzing the paralinguistic aspects of speech in a privacy-preserving way that predicts things like sociability levels or depression in the mental health field. And I wonder about, given the richness of the data we can get, again, without participant burden, but just with this passive data collection through a smartphone, what you think about that kind of approach to sensing either as a supplement to EMA, to get sort of richer data models, or what your thoughts are as part of assessment and intervention delivery.
Oh, I think that's a wonderful way to go, and it's really the way of the future. I think one of the things we would want to make sure is that the data that we got out of them were specific to the individual and not because someone else happened to be carrying the phone. Or one of the things we ran into, we're looking into using Fitbit for measuring activity, but in fact they don't actually make those data available. So I think as we're thinking about adding the, taking these apps or availabilities that are on these phones and applying them to our research, we just need to make sure that our data quality is good and our data access is really good. But I think there's just a phenomenal number of opportunities out there. It's just a matter of capturing them and corralling them into submission.
Absolutely. I mean, this morning I was in a seminar. Francis Collins is, making a presentation on the precision medicine. He raised his arm. He's got Fitbit and iWatch all together. He said actually they interfere with each other. So I think, this thing is moving forward days and nights, yes. I'm thinking, using wireless technology is the way to go, but perhaps make it more streamlined and easier to wear and attractive in looking would perhaps, increase the likelihood.
I think that, and then I think if people see some value to themselves, that would also make people more likely to be willing to wear it. So I think just seeing their heart rate monitor encouraged our participants to carry that phone with them.
Yes. Dr. Collins also showed a slide about, this is precision medicine treating cancer patient, was putting chips into the person's arm. No, but that one was for the blood glucose monitoring. I don't know how far is that going to go for cocaine use.
Yeah, we actually talked to a group that developed sensors, and we were trying to encourage them to develop a sensor that would actually detect cocaine use, because if you could have a sensor that detected cocaine, you don't need an algorithm, right?
Exactly.
So, but his suggestion was to put the sensor in the bladder. But I suggested that was probably not going to work for the kind of things we do. But, there are probably alternatives. I mean. Yeah,
because thinking that they are going to put in buprenorphine, which is implantable buprenorphine, it's a surgical kind of procedure. You can do something where you put buprenorphine in and then make additional slit and then put something else in there to detect, the occasion or whatever. I don't know.
I have a question about your algorithm for treating the first part of your talk, where you use the clonidine in the model and also in patients for cocaine and for opioid. And I assume my new hypothesis is that you might be also looking at, for instance, what they call designer drugs, or that they are epidemic in many parts. Are you planning to do that? Are you doing that already?
Others at the IRP are looking at that. Yeah.
With similar strategies with clonidine.
They're not treating it. They're more at the point of trying to figure out what people are using and what effects it might have physiologically. But we haven't actually done it.
But is your new hypothesis that clonidine might also be effective?
It's possible. Yeah, I don't know what drives
because
people
this is universal, like a universal mechanism.
Yeah, I think that remains to be seen. How generalizable the effect of clonidine is on other drug use.
Anybody else on the webinar has a question for Kenzie?
I have a quick question. This is Shahin Sami out of Memphis. And first, thank you very much for the presentation. It was very succinct. My question regards the human subjects side of this. How receptive was the institutional review board, or did your process sort of flow smoothly, or was this something that took a lot of iterations? And did they have many contingencies or concerns? I'd love to know about how that process was.
Well, of course, we started with self-report, and we kind of had built little parts onto it, and we have not had a problem. And part of it is because the technology has moved with us. So, we're all carrying cell phones, and we're all being really monitored whether we're giving consent or not. But so we didn't have a problem, and in fact, we're just starting a collaboration with Ken Silverman at Hopkins, and we are going to be collecting GMA data in one of his studies, and it was approved the first time through the IRB, so I was actually quite surprised how smoothly that went. So I'm sure it really varies from IRB to IRB.
Wow, thank you.
Any other questions? If not, thank you all so much, and our special thanks definitely goes to Kenzie, Dr. Preston, and for coming all the way here. And we are in the process of scheduling the next one. And if this works well, we will continue this on a regular basis. Thank you so much, and enjoy your afternoon. Bye-bye.